We are live.
A very good evening, everyone. Welcome to the iFocus online class, lecture 445 of the Cataract module. The topic for today's masterclass is tips for successful phacoemulsification. For the class today, I would like to welcome our moderator, ma'am, Dr. Jayita Bose, ma'am. Ma'am has done her MBBS and MS ophthalmology from AMU Aligarh. Ma'am has completed fellowship in cornea and anterior segment from LVPI Institute. Ma'am is currently a senior consultant at Center for Sight Group of Hospitals, Safdarjung Enclave. Formerly, ma'am was an adjunct faculty at LVPI, also a former consultant at Lakshmi Eye Institute, Venu Eye Institute, and IQ Hospital. Ma'am has been awarded the prestigious President Abdul Hamid International Award by Bangladesh Community Ophthalmic Society. She is an active member of Delhi Ophthalmic Society and All India Ophthalmic Society. Ma'am has presented talks at national conferences. Ma'am has also been an invited faculty for training surgeons and eye bank technicians at Lagos, Nigeria, and Dhaka on behalf of International Federation of Eye and Tissue Banks. Welcome, ma'am.
Thank you, Garvit. Warm welcome to Dr. Neeraj Khungar, who is the chairperson for today's class. Dr. Khungar is MBBS and MD from the prestigious All India Institute of Medical Sciences, New Delhi, and currently a senior consultant at Center for Sight Eye Hospital, Ajmer. He is the vice president of Rajasthan Ophthalmological Society, and he has also served as a chairman scientific committee of Ajmer Ophthalmological Society and organizing secretary of ROS Conference 2013 at Ajmer. He is one of the pioneers in phacoemulsification surgery in Rajasthan, and he has participated as faculty in live surgeries, in phaco and SICS workshops, and has multiple presentations as faculty in various ROS conferences. He has presented scientific papers, videos, instruction courses in various national and international conferences. And he has also been awarded the Gold Medal for Distinguished Services in Ophthalmology by the Governor of Tamil Nadu in IIR-SI Conference 2014. We extend a warm welcome to you, sir, Dr. Neeraj Khungar. And now it's my pleasure to introduce our speaker, Dr. Sudhank Bharti. Dr. Bharti has done his MBBS and MS ophthalmology, and he has done FAI CO honors. He's a specialization in cornea, cataract, and refractive surgery in England with Dr. J.J. Kansky and Dr. R. Hitchings. He's the founder of Bharti Eye Foundation, and he's one of the pioneers in phacoemulsification and the first in Delhi to acquire a femtosecond laser for cataract surgery in 2010. Sir has performed more than 50,000 cataract surgeries, and he was one of the first few to start IOL implantation in 1985. He started Phacoemulsification Training Academy in 1998, which was inaugurated by I. Howard Fine, MD from Oregon. And Sir has performed more than 3 lakh refractive surgeries starting in 1985 with radial and astigmatic keratotomy, automated lamellar keratomiliosis, LASIK, SMILE, and now CLEAR. Sir has held positions of President of DOS, President of IIRSI, Treasurer of IIRSI, and Secretary of the LASIK Society of India. And he's also the international investigator for NIDEC for hyperopia correction software, Zymer for clear lenticle extraction in 2019, has presented over 50 original papers in various meetings, including AIOS, ASCRS, ESCRS, AO, APO, etc. He has been conducting instruction courses in various international conferences in the last 18 years, and he has contributed 5 chapters in ophthalmic textbooks. He has been felicitated with various awards, including the P.S. Hardia Award, AIOS in 2006, Dr. T. Agarwal Gold Medal, IIRSI in 2004, Dr. A.N. Pandya Oration, Bihar Ophthalmological Society 2006, Krishna Sohan Singh Trophy, DOS 2010, and the SARC Academy of Ophthalmology Excellence Award 2018, Asia Pacific Academy of Ophthalmology Achievement Award in 2017. Sir, we are very grateful to have you here with us today. And
Thank
over
you,
to
Dr. Jayita, for introducing me. Thank you very much.
Welcome, sir.
Good evening, sir. Good evening, Dr. Bharti.
Good evening, Dr. Khungar.
As it has been highlighted, Dr. Bharti is one of the pioneers in phacoemulsification, and he has a very rich experience in cataract surgery. So today we are lucky that we have him, and he'll be giving us the tips for successful phacoemulsification. As we all know that today phacoemulsification is the standard treatment for cataract, and though it seems that it is a routine technique that we are doing, but there are various type of cataracts, like very soft cataracts, posterior polar cataracts, very hard cataracts, brown black cataracts, subluxated cataracts, where you really need tips to come. Dr. Bharti will be covering all these topics and giving us the tips. Over to you, Dr. Bharti.
Thank you, Dr. Kungar. Thank you. And I'll start with the small 2 slides.
There seems to be some signal problem.
I personally do not have any signal problem, but I am unable to see the presentation here.
Sir, you need to share first, but still not shared.
Okay, but first let me see if I can open it. I am unable to open, but anyway, I'll try to share it. I go to the Zoom meeting and then share screen. And here is my screen.
Yes, sir. We can see the folder, sir.
So now that is shared. And okay. So this screen is visible to all of you, right?
Yes,
Right.
but the presentation is not.
No, but this particular this thing is not opening, so it's okay. I'll not share this. So what I want to start with is that phacoemulsification is a very kind of routine surgery now, and but there is a long learning curve for phacoemulsification. There are a few steps which are very, very important. And as we all understand, the beginning of the surgery starts with the incision making, and then rhexis, nucleus management, and then cortex management. And then after that, IOL implantation and closure of the procedure. And I think the most important thing is that once we are starting to do the phaco procedure for any cataract surgery, the first thing is to do a self-sealing incisions in the cornea, or if you are very not very confident on corneal incisions, then probably corneal scleral, but possibly corneal incisions are the way of to go now. And the corneal incisions are self-sealing, and they don't require much, management once you are closing them, as long as the incisions are square. So that is very important, that the incision should be, kind of square incision. If you're making a 2.2 millimeter incision, which is the most normal today, then the incision width and the length should be about 2.2, and that is the crux of the whole thing. That's very, very important. And also, if it is longer, we must understand that if it is shorter, it continuously leaks and causes, healing problem at a later point in time, as well as the iris prolapse and such things during the procedure. But when it is longer, it induces a lot of astigmatism, which could be, really a big issue at a later point in time. And I've seen astigmatism going up to 5 diopters in incisions which are longer than 3 millimeter, when the width is only 2.2 millimeters. So that's very, very important, that we should plan and do the incisions accordingly. I'll be, I just, because of the introduction, I started this, but I think the most important thing is that we should be talking about the procedure. And what I feel is the video is the best way to, do the talking on that. And then probably I'll start with the, uh, videos basically, so that we can, you know, talk about. So let me start with a little. Oh, why it is not?
Sir, can you do me a favor? Can you just stop share first?
Stop share. Okay.
Yes, sir. Open the
Yeah.
video and then do the share. Open the
Okay.
video, pause, and then share, sir. Thank you.
Okay. So I'll have to minimize this. Open the video first, and then share. So give me a moment. But this is a
Once you are back on Zoom window, just do the share again.
okay. Back to the, it's already started, so we have to kind of stop it.
Just pause it so that
Pause is done, and then I go back to Zoom.
the Zoom window, the same green button and blue button. There's the green button first, then the pop-up comes the blue button.
No, I can't see the green button. I can't see the green button.
Are you able to see the videos?
I can see all my this thing. I can see all my screen, but I cannot see the.
It should be in case you minimize. It should be on the right hand side top. The small window बना होगा. आप उसको expand कर लीजिए. वो minimize करते हैं तो small window बन जाता है. So you just have to click on it on the bottom. If you can see the zoom button, just click on it. The zoom icon. It should open. You must have got minimized. That's it.
Okay, here we are. So yes. Now
the green button, share screen.
Green button, and then
the blue button.
Share the video. Is perfect. That now, is it visible?
Perfect. Absolutely perfect.
Good. So I am starting with the, because what I am trying to show is a situation where most of the people will find a little difficulty in doing, not everyone, but some, if you're finding a little difficulty, then probably this is the video to show how to manage this kind of rhexis in a white cataract. So first you have to stain, and for staining, what I do is I fill the Blu-Rex or whatever you're using as a staining brand, and then fill the syringe half with the Blu-Rex and half with the air, and put it horizontally so that air goes first and then the dye goes into the chamber, and then giving a small nick, and then aspirating all the cortical liquid cortex in this kind of white cataract will flatten the anterior curvature of the lens, and then you can do all this rhexis very comfortably. The only suggestion in all these cases is that you have to do a very small steps. Don't try to pull everything in one go. Don't think that doing everything in one swipe is the best thing to do. Take your time. Always be very considerate to the tissue, and also make it very slow. There is no need to hurry. The only thing is you have to probably finish the whole procedure in about 15 minutes. So that is the timeline for a cataract surgery, that you should be able to do that. But beyond that, nothing to make it uh, very quickly. You don't want to do it in 2-3 minutes or 5 minutes or whatever you hear in the meetings. So that is not the idea. The idea is to manage everything comfortably, whatever speeds suits you. In these kind of cataracts, the best thing is to, once you have emulsified a quadrant, you to keep on injecting a little bit of viscoelastic every time you have removed a quadrant, so that the endothelium as well as the posterior capsule are safe, and you can remove all this comfortably and quickly. So I think the rhexis part and the nucleus management part is easily, you can appreciate that these two things are all very comfortably achieved in this particular case. And as you can see in this eye, the rhexis is not very large, so we'll probably need to enlarge it if you think that you can do that. Otherwise, after injecting the IOL, which is always, of course, a foldable IOL in my case. But if you need to increase the size of the incision and do a non-foldable PMMA lens, that also can be done. There is nothing, great about that. And then you can enlarge the rhexis here by the using the rhexis microforceps, which can enter without flattening the antechamber or making the viscoelastic leak. All these surgeries are not been done with a very high-end viscoelastic, which is easy to manage all these situations. Here I am using in all the cases the Indian HPMC normal 2%, so that it is not something which we are using very hi-fi in all these cases to manage, because that is not the thing which I think initial phase of the life you will get. Of course, if you are working in an institution, you can always, but in majority of times you get normal viscoelastic in India, and that is the way to do that. So here you can see that the rhexis has been enlarged to a sufficient extent so that there is no phimosis at a later point in time. And then the other thing which I want to show here is to wash the viscoelastic from all around over the lens, and also I'll try to go behind the lens as well. So if you press one end of the lens, the other end is always a little bit elevated, and then you can go behind the IOL and achieve a very good removal of the viscoelastic from behind the lens, which is very, very important, because then the toxic lens syndrome or a situation where you have left the viscoelastic behind and then getting a little bit of inflammatory or opacified fluid in the back of the IOL is not there. Because if you do in all these cases, you have to go back and wash it. It's better, because sometimes that cortical fluid which is there, which is slightly opacified, can cause a kind of aseptic kind of reaction at a later point in time. If you do a YAG capsulotomy to, if you assume that it is a posterior capsular opacification and want to remove that by a posterior capsulotomy, but YAG laser capsulotomy, and it goes into the vitreous, it can cause issues. So this is one thing which I wanted to show. Then we'll go forward. Probably I have to, if I want to show another video, admin, how will I go out? Now can I close this top window from the top, or I have to go back to my old screen? Hello, can you hear me? Sorry, he is not there. So I'll say stop share. and then probably,
Yes, sir. You can close the video, sir, and go back to the original folder.
okay, close the original video. Okay, I have now
Back to the
closed
folder,
the
and then you
video.
start playing the video,
And yeah, fine.
and again share your.
So the next video which I want to show is, let's say this one I'll open it, and then, okay, here we are. And then okay, no.
Sir, I think you play the video, then you share your screen. That green button you have to click on the screen.
I cannot see the green button, actually.
So please maximize the zoom.
But you
Sorry?
must have minimized the zoom, just expand the zoom. जैसे पहले हुआ था, आपने minimize कर दिया होगा. Just go to the zoom icon of the window. You should be able to see it.
Oh, okay. I don't know why I'm having this problem earlier. So many times it has not been there at all. But then this time it's.
Sir, can we try sharing the presentation in case you are having this difficulty? Can we try sharing the presentation?
You want to share the presentation to you?
No, I'm saying you have the presentation, right?
Yes.
Would you like to show on the
No,
presentation?
that presentation is not working, sir. That is the problem. That is the problem.
You can open all the videos and minimize them. Once you have minimized them, then you can start on opening from below once you have shared the screen.
Yes, sir.
Okay, so let me see. I have to open all the videos.
Sir, all the videos में वो overlap करेगा. एक time पे एक ही चलाएगा videos.
Okay,
just come back to the Zoom window where you see all the videos of everybody.
Okay.
There. You should be able to see that.
Yes.
You should have that green button at the bottom.
I cannot see the green button. I can see only one admin support. This one. Yes. Okay. Now I start the video and share.
Just follow the same steps again, sir. Yeah, just share the button, sir.
Share button first. Actually, share button is not visible when I'm starting this, unfortunately. So I don't know.
So just stay on the Zoom window where there should be share button.
Yeah. Is that okay? Now can you see it?
You need to share, sir. अभी share नहीं हुआ.
No.
The green button and then the blue button.
Yeah. Now can you?
Perfect, sir. Perfect, sir.
Okay, good.
Sir, abhi just ensure you don't stop it. Just start opening the videos, whichever you want to share.
Just start the video from the beginning.
Yes,
okay,
sir.
I can start it from there. And
yes, visible, sir. You can.
okay. So now this is another interesting case. I have got a couple of interesting, but if this. So here is a case of a small pupil where I've tried to dilate the pupil. That's another important issue with the phacoemulsification, because you need to have a fully dilated pupil, a good rhexis, and then you can do a phacoemulsification. So I'm trying to, detach the synechia and then mechanically dilating the pupil. I would not suggest that mechanical dilation is the best technique. Depending upon the circumstances, mechanical dilation should be a good technique, especially in those cases where the pupil, you don't need to, have a very small pupil at a later point in time. So our medium-sized pupil will continuously remain after mechanical dilation, because this will break the the constrictor muscles of the iris. And here I am going to use a Zepto technique, because I thought that pupil will not be able to dilate to that extent. So that is why I'm using a Zepto handpiece, so that we could have gone behind the pupil and used the Zepto. But in this particular case, the lens is slightly tilted. And since the crystalline lens is slightly tilted, it is an old glaucoma case. So you can appreciate that the rhexis is not complete. The Zepto has not been efficient in, making a good round rhexis. So after realizing that this is not complete, I am trying to complete it with the micro rhexis forceps, and trying to complete rhexis which is completely round and good. And then probably once you have removed the remnants of the capsule, entire capsule, and completely made it round so that there is no tear in the rhexis at later point in time, once you have finished the phacoemulsification, you can start doing rhexis, and be very careful in all these cases where there might be a little bit of zonular weakness in all these cases, as you can appreciate. So in these cases, it is very important to be very, very gentle, and very, you have to keep a situation where the pressure of the instruments do not press the zonules, do not give any stress on the zonules, so that there is no break of zonules or dehiscence of the zonules because of the pressure on the nucleus. And then you can gently remove, gently rotate, and then or emulsify the quadrants into different quadrants, and then remove gradually and peacefully. The most important thing is you have to be patient. And once you're patient, it's initially all the complicated cases or all the difficult cases are your test of your patience. So you have to be very, very patient in doing all this. And gently you can insert the IOL also without disturbing. And since we have lost a little time in this, so I want to show another video. I think rest of the matter is not a big issue. And okay, here we are. And we'll share the screen. And yeah, here we are. And this is the video which I want to show. This is a case. Can you see this video now? Is it visible?
Yes, sir. Yes, sir. Visible.
Good. So great. This is a small short video of a rhexis which is going away, and it is going peripherally, and then probably I have to retrieve it. So this is one thing which I wanted, that there are two methods of retrieving this kind of rhexis. We have done the staining of the capsule, and then I've started doing rhexis with my normal capsulotomy cystitome. And then gradually, if you see, no. Let me see if it is the same. I thought that is the same video which I wanted to show about, but this. Let's go a little forward. Yeah. So this rhexis has gone a little peripherally, and here there are two factors which you must keep in mind. One is that the rhexis is going away because it has entered the area which is, having the zonular attachment. So zonules are attached in this particular part of the anterior capsule. And once your zonules are attached, they will keep on pulling the rhexis out. And there are two methods. One is to, cut these zonules with the cystotome gently, which I'll show you, or otherwise keep on pulling, tearing these zonules very, very little bit every time. And then you can, retrieve it, you can bring it back in the center. So this is the way you, as I said, all these little bit of difficult cases are test of the patience of the surgeon. So you have to be patient, and a little bit of time, if it is taken, don't get kind of frustrated because of the time factor which is going on. And one has to be very slow, gentle, and very tissue should be properly respected, so that. And the most important thing in all these cases, it is very important for continuous visibility during the procedure that you do not disturb the cortex by either pushing the the flap of the capsule, anterior capsule, or by going behind the capsule, so that you think that you can push it or go behind. And once there is a muck created behind the capsule and in the cortex, then it is very, very difficult, because then visibility goes down drastically and it will be very difficult for you to go back. So it is very important that you do not press or injure or go back into the cortex when you are using this. And I don't know why this and you have to keep on injecting with viscoelastic and keep the center. And as I must mention here, that rhexis is a procedure which has to be done in a high magnification. Rest of the procedures, rest of the phacoemulsification can be done in a lower magnification, but whatever maximum magnification you can tolerate, that is the best for you for doing a good rhexis. So a little bit of high magnification is very important, so that visibility is good. And then, as I said, if you continuously be patient and keep on pulling the anti-capsule tag, anti-capsule fold, then you can bring it in the center without much of an issue. And of course, it takes a lot of time, but that's very important that you give it time, so that, but the more important thing is that you keep the visibility good. And as you can see here, I have been able to bring the capsular fold here in the center, and now it's not very difficult. Now one can bring it and complete the rhexis. The important thing is rhexis has to be complete in all quadrants, so that there is no tear in the rhexis, and visibility is good. Here I have been able to achieve this rhexis, and probably yes. And now it's not difficult. Rest of the issue, once you have achieved a good rhexis, then there is no issue on that. Let me show you another way of, okay, here. Okay. Yeah, the second one is again, okay, and share the screen. And this is the second video which I wanted to show you. Again, this is a white cataract, and I have stained, and I have put the air first, so that there is no staining of the endothelium, because sometimes there is endothelium which is stained with trypan blue, and then the visibility of the cataract and capsule is slightly compromised. So that's not a very good idea. I'll make it a little fast forward. Let us go forward and see what happens. So here I have started the rhexis. The flap is visible, but it has gone here in the periphery. And then the game of the patience starts, that you have to be patient. Now I have tried to, start it from the other side. I began the rexus from here and then went on the other side port, but that is actually not a very good idea, because you cannot keep pulling in the wrong direction, because there has to be a tangential force, which is, it has to be perfect to make the rexus larger. So, and go forward. So there I have started again, but here what I am trying to use is that I'll cut the zonular fibers which are attached up to the nearly peripheral, about 2 millimeters of the anterior capsule. So in all these cases, your cystitome can cut these fibers gradually. And once you have cut these fibers, then it is easier to bring it. So I'll demonstrate as to how we can cut these fibers. So here, if you gently, in the periphery, if you go and gently rub the tip of the needle on the anterior capsule, the zonular fibers are cut. Here, I think you can appreciate, though it is right now not well centered, but then if you can appreciate, this is going to be the way to go. And as I said, don't create muck. If you create muck, the visibility will go down, and then it will be very difficult for the rexus to be, you cannot visualize the rexus and then follow it further. So if we go forward and see, here I have tried to bring it in the center, and here you can see my needle tip is in the periphery where I am trying to cut the zonular fibers. In a moment, it will come in the center, and then probably everybody will be able to appreciate it better. So, and then keep on pulling the flap, capsular flap, so that it can go. Yes, this is, here we are, and you can see that there is, little bit of zonular cutting which I am doing with the tip of the needle. You have to be careful that you do not tear the capsule or cut the capsule while doing it. But then once you have cut, taken away that, that pulling, capability of these zonules, then you can bring the rexus in the center. So this is another very important thing which can, happen while you are doing the rexus, and then gradually you can see I am going into the periphery and then bringing it forward. And now gradually, once these zonules they have given way, then they will allow you to pull the rexus in the center. This is very important. And sometimes these zonular adhesions, zonular attachments or insertions of zonules is visible under the microscope before you start the surgery, especially in the cases where the red glow is clearly visible. But in all these cases where the cataract is white, the contrast is poor, and also red glow is not there, this attachment of the zonules is sometimes not visible, and that is why it is sometimes you land into such situations where you need to, and you can see that these zonules I am cutting with the tip of the needle, and once you have done that, then probably the rexus will come under your control and you can bring it, So here it has come under your control, and then you can go forward and complete it peacefully without any serious complication. Here you can bring it in the center now. You can see that the zonules have, left that area and you can see now I am able to bring it into the center. And once you are able to bring it to the center beyond the attachment or adhesion, attachment of the zonules, then it is not very difficult to complete this kind of rexus. Sometimes you have second time also this can happen. So again, you can use a little bit of maneuvering to cut these zonules again, like here I am doing, and then you can bring it again back into the center and complete. As long as your rhexis is not broken, you can do the phacoemulsification without any problem. Now, another video which I want to show is posterior capsular rhexis, and so once you have given in all these conditions where you have to do a posterior capsular rhexis, you have to make a small nick in the posterior capsule first, and then you should have a micro forceps. And here also, I'm not using anything like a very high quality viscoelastic. I'm using whatever is available as routine surgeon in our country, the HPMC, and trying to pull it. The only tip for this is that do not try to overinflate the chamber. Once you have not overinflated the chamber, you can control the posterior capsular rhexis very peacefully without much problem. But if you have overinflated the chamber, the posterior chamber between the then the posterior capsular rhexis tends to run out. So it has to be optimum inflation of the bag, which is important. You cannot think of overinflating and then getting into more trouble. I am showing another video, which is how to manage a small pupil. So there are many methods available, but the most kind of atraumatic system which is available for pupil which are non-dilating, or like in this case, there is a case of uveitis where there is adhesions and synechia all round. So in all these cases, you can use whichever device is available. The best for me is Malugin ring, but for the sake of demonstration as to how to use the iris hooks, it's now it is very easily available in the country and manufactured by our own Indian companies. So you can use them and start hooking one after the other and make you can use 4 or 5 or whatever number of iris hooks you want to make the pupil round and comfortable for yourself, so that there is almost an opening of about 5 to 5.5 to 6 millimeter to allow you to make a rhexis which is at least 5 millimeter in size, and then you can go forward, because 5 millimeter pupil is very comfortable. And here I have done, and after that the other things are all routine. The more important thing is probably the removal of the rings, the iris hooks. After that, here I am trying to remove a small plaque from behind the lens once I've implanted the lens with the needle. As I said, that needle is a very good tool. It can cut depending upon your hand and the pressure which you can exert. There is a possibility of removal of the plaque. After that, once I've removed the plaque of this posterior subcapsular or a little bit of posterior polar cataract, then it is not very difficult to see that the vision will be good. Otherwise, the plaque would have obstructed. And there you can remove these iris hooks one by one by taking them out, and probably you can either take them out or pull them from the other side with a micro forceps. So it's very easy, and you can see that despite that the pupil was enlarged to about 5.5 millimeter, once the iris hooks are removed, it will go back to about 4 millimeter in size. So they are reasonably atraumatic, not as good as myelin ring, but they are reasonably atraumatic to allow you to have a pupil which will not be, incapacitating to the patient because of large size at a later point in time, and will not cause much of photophobia at a later point in time. I want to show the how to implant the Malugin ring also, and that way this is the another case of uveitis, and where I'm going to use a Malugin ring. Now Malugin ring is available in two sizes, and also a thinner Malugin ring which is very easy to use, and actually it is much atraumatic. When you have an initial pupil size, if it is not something like having a synechiae, when you have initial pupil size of about 4 millimeter in, or maybe 3.5 millimeter because of the rigid iris or such conditions, you will see that after the cataract surgery, the pupil comes back to about 3.6 or 3.7 millimeter. So it does not dilate or becomes traumatized after the Malugin ring. As you can see here, once you have put the Malugin ring, it's very easy to manage everything. Once you have done a good rhexis of the size of 5 millimeter to 5.5 millimeter, you can, once you have put a Malugin ring, it's just like having a pupil which is normally well dilated. And then once you implanted the IOL, you can pull the remove, take out the flanges of the Malugin ring, and then pull it out of the main port, or maybe you can, explant it by putting the same, injector and pulling it inside the injector like here. And it is not very difficult. Once you have done it, just be slow, and it will not be. And you can see that the pupil is reasonably well, sized, so it is not, traumatizing the iris at all, and it will not, remain like damaged, so that not very difficult to, do this. I want to show a little video of the IFIS also in these cases, because this is a this patient came with this iris chapping created by the previous surgeon, and he could not even start the surgery. I started,
The video is not visible, I think.
Sorry?
The video is not visible. I think you have not shared the screen.
I have not shared the screen. Oh, I thought I have shared the screen. Okay, let me see. Okay. I don't know. Earlier I could share the screen so well. Now I am not able to share the screen. Yeah. Is it visible now?
Yes. Yes, sir.
Yes,
It is.
sir.
Great.
Yes,
Great.
it's visible.
Iris chapping created by the previous surgeon, and he could not even start the surgery. I started, I wanted to start the pump at another point, and mediated access. Access potential. And procedures. And you can see the iris has already started collapsing. This one. Right to go ahead. I thought that I'll be able to manage. I think that this severity of the aspect, I used the second, which is this was engaged. And despite that, that is fine. Okay. Despite of the three things used, there is a little bit of four, two, This volume because of that swapping. First, and ports are hydrated. Iris is pushed back. And AC is formed with the BSS. This is how we manage the iris successfully. Three tools for management of floppy iris are intracameral phenylphine to reduce varices, high density viscoelastic to push the iris back, and pupillary dilated device to keep the pupil dilated. It is designed to manage iris. Thank you. Thank you very much. So do we have time to show one more video, or we close the meeting here? It's about what? 3 minutes to the 9 o'clock.
Sir, we can have one more video if it's
Okay.
within 2 minutes.
Okay. Okay. So let me see if I can.
Any questions from anybody? If there is anything.
Yeah, that will be more than welcome. And
Sir, there is a question from Dr. Krutika. Is there any specific condition or case where scleral incision phaco is preferred over limbal or clear corneal phaco?
so just a moment. Okay. So I think the only reason why you want to do scleral is probably in all those cases where you want to do a superior main port and don't want to have any astigmatism, create kind of astigmatically neutral incision from the superior side. Because majority of times, if you are superior, you create a lot of astigmatism, could be up to 1 diopter. And the second possibility is that if there are any peripheral corneal conditions where you cannot go into the eye with the corneal, corneal sections, because that's very, it could be kind of non-healing situation at a later point in time. So those two conditions, I think we might consider making a scleral.
I like to add here. In operated RK cases, radial keratotomy cases, when there is very less space between the two incisions, I think making a scleral incision is a choice. That is what I usually do.
Okay. If I may interrupt, I have done majority of cases which are done initially only by me. In all these cases, 90% of my RK cases had 8 incisions only, no more than 8. Maybe 10% had 12. So in a 8 or 12, incision RK, you can do a area, you choose a area which is, incision free, and still go ahead and do it. So but if you have multiple incisions or multiple times RK, then it is very difficult. In those cases, scleral is, I think, preferable. Definitely.
Sir,
Yes.
also in post PK, I think if it's a graft, there's a graft in the eye, post PK cataracts also, scleral incision would be
Absolutely.
preferable.
Well, that is covered under our peripheral corneal condition, I would say, because that is a very elaborate answer if I want to enumerate the conditions of the cornea and the periphery.
Right, sir. And there is one more question. What is the preferred method of doing posterior capsular access, a vitrector or forceps?
I don't think vitractor will be as good as a forceps with me, at least. As far as I know, because to have a vitractor, you can, once you are in the process of suction also along with that. Sometimes I have done it a few times, not many times, because my I can do it peacefully with my capsular access micro forceps also. But I've done, and sometimes there is a large cut which is more ragged. It is not like round in the center, which I want, and then you have to increase the size. And especially if you're wanting to do something like 2.5 to 3 millimeter. You cannot go in a posterior capsular access. You have to be 3 millimeter, around 3 millimeter, and not more than that. So that is very, very important, that the size of the posterior capsular access has to be very controlled, which I don't know I will be able to do with a vitractor or not. Though I have done vitractor access, and I have presented vitractor access in my own cases, which I have a video also, but that's something different. But it sucks the cortical matter in a very case with a high intralenticular pressure, and in that cases the vitractor access is very comfortable.
Right, sir. Would you like to show another video, sir?
If we have time, let me see if I have the video, or people are ready to.
Any other questions? Anybody would any comments?
Ma'am, there is one question on YouTube. Question says, any tips for during IOL implantation to make sure effective lens position is accurate?
So effective lens position is, may I?
Yes, sir.
Yes, yes.
Yeah. So effective lens position probably has two things. One is that you have to be in the bag. And second thing is you have to be washing the posterior, the viscoelastic behind the IOL very, very, meticulously. So that's the way I think, positioning of the IOL. I have one point to know, one comment to make here. If you're using a multifocal IOL and you implant it in a vertical axis, 6, 12, every single time you will have the center of the ring of the multifocal lens right in the center of the pupil, because the configuration of the bag is such that if you implant the lens in a horizontal manner, which is 9-3, then the central ring, the central ring is not in the center, it is slightly temporal, because pupil is slightly shifted towards the nasal side. So I have tried multiple times, maybe 100 times or more, and vertical orientation of the IOL in the multifocal IOL always gives you a very centralized, ring in the central ring in the pupil center. And I feel that is that gives least halos and least contrast issues once you have put that, because no ring is coming in the center of the pupil. So I don't think if you're talking about the horizontal or whatever, or steep axis or whatever, the thing is that if you want to remove the posterior viscoelastic from behind the lens, and you will get the effective lens position at the right plane. If you have anything else to suggest, I'm welcome for that, please.
Dr. Neeraj Kungar sir, any comments from you?
That is rightly said that basically the most important is to remove the viscoelastic band. And if it is not a toric implant, we should do it vertical like 612 as has been rightly said. Otherwise, the ELP, is something which cannot be determined pre-op, and it is a automatic thing where the lens sits in the eye. That is why we have so many optical biometers and so many newer formulas. But these are the surgical tips which we can do so that the ELP is the best we can get.
One more question, ma'am. Sir, what
I
are the
think note on very hard black and brown cataracts. I think that has not been covered. Sir, do you have any video on some black or brown cataract? You want to give us a tip on that?
I have not right now prepared a very hard cataract video, though I have many, but a hard cataract video is there. If you want to see that, I can immediately, it's there in the same this thing also. So you want to have a look, then because I think there are two ways to manage the very hard cataract. The one way is to make a four quadrant management, which was there earlier, or the second is the nucleus, making a nucleus very small by kind of what do you say, removing the thick epinuclear plate from the surface and then do the removal of the nucleus, and so that when you're using a high energy phacoemulsification, you will not damage the posterior capsule. So those two tips are there. You can do a quadrant removal method, or you can do a removal of the the cortex, tough cortex, remove it from the nucleus and then take out the nucleus and then move. This was the video also presented in the ASCRS almost 20 years ago by Kumar Doctor. So if you want to see that in situ removal of the cataract and a very hard cataract, that video should be available in the ASCRS archives.
What I usually do is that I make a very deep U trench in such cases. Yes. That is in the central part. So then chopping the cataract becomes much easier, because the backbone, which is usually not separated, especially in diabetic leathery cataracts, here you can do that. So you make a U-shaped trench in the center, which is quite deep enough, and then you start chopping, and then you chop it into 6 pieces or 8 pieces, depending on what you want to do.
If I can offer one suggestion for a surgeon who is starting phacoemulsification and is proficient in SICS, because in our time there was no SICS, so we don't know, we didn't do this, but anybody who is efficiently doing SICS and is going to change into phacoemulsification, my suggestion is to make a trench, and when the surgeon thinks that he has reached more than 70% of the depth of that nucleus, take it out with SICS and analyze it under the microscope, how much depth you have actually reached. And majority of times you will find, or my trainees, when I do that, they find that they have reached only 50% or less than 50% of depth of the total nucleus. So once you have reached that, you know that you get scared early rather than late. So very, earlier, once you're learning, you get scared very early and then probably do not go to sufficient depth of the nucleus to, kind of break it into two or separate the two quadrants or two halves. So that is the first thing to understand. And that is where the hard nucleus also, you can trench it to the situation where you can see the red glow through the nucleus. You will still not reach more than 70% or 80% of the depth of that. and then you can, kind of chop it into two, chop or maybe separate into two halves.
Very, very, very good tip you have given, I think, for the beginners. And that will, in a way, they will be very sure that what is the exact depth of trenching they have to do. It's a very good tip. Thank you, Dr. Bharti.
Thank you. Thank you.
Right. Sir, any tips for posterior polar cataracts? What is your technique?
Posterior polar, if it is real posterior polar, one is that we should realize what is posterior polar and what is a thick posterior subcapsular. So majority of cases which we see is thick posterior subcapsular and they are not posterior polar. Posterior polar is either you are seeing in the slit lamp that there is a kind of defect in the posterior capsule and that is only posterior polar, or you can see the fishtail sign, or there is, if you are doing a B scan, then probably you can see that there is a defect in the posterior capsule. In all those cases, couple of things are more important because most of the posterior polar cataracts will cause, diminution in vision or visual disturbances very early. So they are all very soft cataracts, and they can be, you can do it with a little more power than only IA. So put your machine in the what do you call, the mode where there is a very little power but high, not very high but high suction, like 450, 500 suction, and a flow rate of about 40 or 36. So in all these cases, this matter, the cortical matter along with the nucleus, they will come like, a plate without doing any hydrodissection, because hydrodissection and hydrodelineation is not, I would not say, unless you understand exactly that you can do a hydrodelineation without hydrodissection, then only you can attempt that, because hydrodelineation is in the center and it is to, make the nucleus smaller part which is phacoable and remove the cortex out completely. So in all these cases, you put just a, phaco 3 mode where there is very little power and you can remove the, and then probably more than 80% times you'll find that there is a posterior capsular defect in all these posterior polar cataract. And then you have to be very, very gentle, and suction and irrigation, everything, and aspiration, everything should be in the low mode after that, so that there is no, but majority of times in all these cases, since the patient is young, the vitreous phase does not get disturbed. So that's very important that you don't get scared unless you are doing something which is not, gentle. The posterior vitreous, the antivitreous phase is not going to disturb. The only thing is that you have to be very clear and do not do any phacoemulsification if there is the nucleus can be, managed with very low power. That is my tip. Yeah.
Right. Dr. Khungar, anything you would like to add?
Posterior polar, like first thing I like to add is that when you, if you have access to a ASOCT, you should do that if you doubt that. Second is that even if you don't have that, if you have IOL Master 700, it has the SSOCT base, and then there also you can pick up. And once you know that there is a clear-cut posterior polar cataract, you should have a sensor 3-piece, like any 3-piece lens handy. So that power you should always have in your OT before you take up the case for surgery, because there are high chances that. And then, as everyone knows, we are not to do any hydrodissection in such cases. And because of that, it is better that you have a slightly larger rexes, maybe 5.75 to 6 millimeters.
Sorry. May I interrupt, Dheeraj?
Yes.
I want to do a small rexes. I want to do something which is smaller than 5, because if I have to do a capture, IOL capture, optic capture, then a large rexes will not allow me to do that. But anyway, please go ahead. Sorry.
Why I'm saying that is that it should not be very large also, and it should not be very small, because once we have not done hydrodissection, it becomes very difficult many a times to remove the cortical matter, because it is got stuck inside. If you have a very small rhexis, practically many a times it is very difficult to remove the epinucleus and like that from the subincisional area, and that is why I'm saying that we should have slightly 5.75, and you are right, and it should not be large, because you have to be ready to place a sensor 3-piece lens in the sulcus and do the
For
optic
me,
capture.
a good rhexis will be something like 4.5 to 4.7.
Right. So I think there is one question by Dr. Krutika. Krutika, would you like to ask? Are you there? There is on the chat. What are the precautions to be taken as an anterior segment surgeon while doing phacoemulsification in a subluxated cataract?
Okay. Subluxated cataract, first you have to assess whether you'll be able to do it or not, because let's understand that a peacefully, simply, primarily done ACIOL with the designs which are available now is safer and less damaging as compared to the phacoemulsification. If you're using multiple devices, so this is my first suggestion, that if you are able to do a ACIOL very nicely under peribulbar anesthesia, then probably that is the best bet. But if you want to, definitely want to do a phacoemulsification with lot of suturing, maybe suturing of the ring and everything, then probably you have to have tools which can hold your subluxated nucleus, the rhexis, and the rhexis hooks, and all such things should be available before you go ahead. And also make sure that the cataract is not very hard, because then if you're using a very high power while emulsifying that cataract, you're going to very damaging to the eye. So you have to have a lot of options to doing that. I personally feel that the IOLs which are available now, they are absolutely wonderful. But if you want to go ahead and do, then probably very slow, low parameters, phacoemulsification, and a lot of viscoelastic, other tools, availability of all the tools in the OT, so that there is no subluxation is not increased. And then as soon as possible, you can, suture the ring, everything. So that is, I think, the way to go. That's the way. Yeah.
Okay. Anything you would like to add, Dr. Neeraj?
Yeah, I think he has covered almost everything, but one small tip I'd like to give, that the rhexis, when you start, the rhexis should be 90 degrees away from, basically it should be 180 degrees away from the place of subluxation. So you are not pulling on the part where it is subluxated when you are starting the rhexis. Otherwise, everything Dr. Bharti has covered very well.
So I think if there are no more questions, we can wind up for today. And I would like to thank our speaker, Dr. Bharti, for taking out the time and for explaining to us so many wonderful tips and showing us these lovely videos. And we gained a lot of knowledge from your experience and your surgical videos. So thank you once again. And also I would like to extend my thanks to Dr. Neeraj Punger, who was a chairperson for this session, and Dr. Garvita and Krutika, who were basically instrumental in starting off the session, and for all the audience and the admin support, thank you very much, and wish you all a very good evening, and till we meet again, thank you.
Thank you, ma'am.
Thank you, Dr. Jaita.
Thank you.
Thank you. Thank you, guys.
Thank you.